visualization that is pretty common to the way health systems analysis using DEA is performed. So on the left, the figure shows various formations of production functions. You have, of course, a constant returns to scale at the 45-degree angle between output and input. And you also have a variable returns to scale production process. And then you have something which is perhaps a non-increasing returns to scale, which could happen in areas where we see decreasing efficiency. So in terms of DEA, the analysis proceeds fairly conveniently because it does not require us to specify a production process in terms of parameterizing it and giving it a very defined shape. And this is a unique property of the type of analysis that fits health systems where we may not have a very good understanding of exactly what parameters link the conversion of inputs to outputs. And this is a way that we have also applied DEA to our own work in global health. Next slide, please. And realize that some of the advantages of DEA are fairly well suited to the types of health system questions we want to apply. So since no production frontier or production function specifically needs to be parameterized or specified in DEA, it lends itself well to health systems or health program analysis. And this has actually been done more and more over time in the last decade. The other aspect of this is that it can adapt and use multiple inputs and multiple decision-making units as part of the analysis. I'm sorry, if you are unmuted, could you please mute yourself at this time? And the analysis is now facilitated by the availability of analytical procedures in commonly used statistical programs, such as data. More recently, I think we have a literature that has developed to apply DEA to health systems analysis. And we have a few citations here on the slide. And these give you some examples of how you could conceptualize applying DEA to questions that would compare a decision-making unit such as a subnational government or even countries to each other on a defined relationship between outputs and inputs. While these are important and useful strengths, there are some weaknesses to the use of DEA. The efficiency score that may have been computed or generated for one decision-making unit in a specific study is hard to compare for the same decision-making unit in another study, if even there are small changes to the other decision-making units sampled as part of the study, or any changes to the inputs that are used as part of the study. So that lack of comparability sometimes can be a challenge. The second is the type of data that are available on inputs and outputs, and the number of decision-making units for which we have comparable data can sometimes force us to use a simpler specification in terms of what we are including in the DEA. And of course, as part of that inclusion problem, we find difficult to apply quality concepts to the evaluation of different decision-making units related to their efficiency and the performance. So how well does DEA actually perform in informing policy decision-making? And this is something that our project is particularly concerned about. We would like to understand decision-making in the context of health sector reform and macro-level health policy making. So the example that we would like to present today really goes to this specific weakness in the literature and looks at a decision on health sector reform and its impact on health facilities, so decision makers at the level of hospitals. We've also applied DEA in our project to look at a decision to contract private facilities as part of Malawi's overall health sector reform. And that study is another example of how to examine a policy decision. Next slide. Yet decision-making, of course, sometimes requires people who are not as familiar with economic concepts, but would still like to use evidence as part of their decision-making. And from time to time, we have to use other approaches that are more tractable and perhaps amenable to the data available and the audience which will be informed. So here, the long-standing approach of using process measures, which are generated as part of the routine execution of the production process, might be convenient, though they do come with advantages and disadvantages. So while it's easier to understand ratios which are generated as part of a health production process, such as say unit cost or some other kind of input-output ratio, these are, of course, not a very sophisticated measure of the underlying production function. While they are easily understood, they are usually limited to describing the part of the health production process that is better observed. So can these process measures be improved in ways that are useful to policy decision-making? Perhaps. One way would be to combine many of these process measures into a composite or an overall mix. And one way to make a composite is to link these process measures that are comparable using weights. But as economists know, one of the traditional challenges of using weights is how will we defend generation of those weights? And this is a difficult methodological challenge. But another one is if we do create process measures or even DEA analyses, how can they be best linked to real world decision-making and uncertainty? So today we will be presenting two cases where process measures are used, one at a program level, in this case, the family planning program, and a second at a subnational unit of decision-making, so the county governments in Kenya. And I think we would appreciate your feedback and your questions using the chat function on how you might be able to use similar types of process measures in your work. So with no further ado, I'm going to turn it over to my colleague, Rebecca Ross, to start us off on the first case, which is the use of DEA. Over to you, Rebecca.
Thanks, Rin, and good morning, everyone. My name is Rebecca Ross, and I work on health financing and economics at HP Plus Palladium. And today I'm going to discuss the use of DEA methodology to assess whether the initiation of Indonesia's single-payer national health insurance scheme, Jaminan Kesehatan Nasional, or JKN, is associated with greater efficiency in private hospitals. Next. Initiated in 2014, JKN had planned to reach universal insurance coverage by 2019, but there's also concern that JKN payment mechanisms incentivize overtreatment and therefore inefficiencies for the scheme. The scheme administrator, BPJSK, pays contracted hospitals for outpatient and inpatient care with Indonesia case-based groups, or INA CBGs, a diagnosis-related reimbursement, where payment rates are determined by type of diagnosis, severity of the condition, geography, and hospital classification type. Because Indonesia does not have many national treatment guidelines, excluding services for diseases like HIV and tuberculosis, which are traditionally donor-funded, providers have some flexibility to optimize facility resources for treatment procedures, interventions, and drug administration. Some suggest that there are increased instances of overtreatment, financial strain on hospitals, and possible compromises in quality of care. Unlike public hospitals, where government funds personnel costs and capital expenditures, private facilities must fund most costs from their direct revenue. They also have to procure medicine and commodity needs from the market, whereas public-owned hospitals can access a government-implemented procurement system. And given that hospital expenditure accounted for 80% of JKN healthcare expenditure, and as of 2017, when this study was started, over 60% of JKN affiliated hospitals were in the private sector. Our analysis aimed to discern whether hospital use of resources had improved since JKN initiation, that is, whether technical efficiency had changed. Next. There have been few studies to assess technical efficiency in Indonesian hospitals since JKN initiation, and those that have only considered public hospitals and did not consider whether this change was related to JKN. So we designed a two-stage analysis. First, we used DEA to measure technical efficiency of hospitals, both before and after JKN initiation, in 2013 and 2016, respectively. DEA, as Arin Explained is a linear technique to quantify efficiency by assessing the proportional change of multiple inputs and outputs used. So we created 4 separate DEA models to differentiate between inpatient and outpatient departments in each year. DEA models were oriented to maximize outputs, assuming that hospitals plan budgets in advance and do not have the ability to quickly adjust investments in infrastructure, equipment, or labor. Next. In the second stage, we use the DEA output, the efficiency scores, to assess whether changes in efficiency were related to JKN via hospital contract status with BPJSK. To do this, we developed 2 truncated regression models for inpatient and outpatient departments. Covariates included geographic group, urban versus rural hospital setting, population density, hospital classification type, and hospital ownership. Next. Our analysis utilized data collected in a study conducted by HP Plus of private hospitals' capacity, utilization, and finances before and after JKN initiation. The data was collected from December 2017 through January 2018. Operational data, including data on outpatient load, inpatient capacity and occupancy, services available, and human resources, were collected from 73 private hospitals in 11 provinces, representing about 5% of registered private hospitals in Indonesia. Hospitals were stratified by province, classification, and facility ownership. We used contracting status, whether the facility is contracted with BPJSK or not, to note the initiation of the JKN policy change. The survey was administered to 61 contracted hospitals and 12 non-contracted hospitals, representing different hospital specialization classes, B through D. And again, the data was collected from 2013 and also 2016, so before JKN initiation and after. And specific inputs used in the DEA and in the regression models are detailed on the right here. Next. Before generating the efficiency scores, we looked at descriptive statistics of inputs in both 2013 and 2016. Installed capacity increased among both contracted and non-contracted hospitals between 2013 and 2016. And qualitatively, we found that providers perceived patient utilization to have increased since JKN initiation, with 81% of all surveyed hospitals reporting increases in patient volume and bed capacity. As you can see here, inpatient beds and human resources, including general practitioners, nurses, and specialists, increased among both contracted and non-contracted hospitals, and only the number of outpatient clinics decreased between years in non-contracted hospitals. Next. We also considered the descriptive changes in outputs. Unlike the inputs, we see that overall trend of outputs between years differed among the contract status groups. Generally, outputs increased among contracted hospitals and decreased among non-contracted hospitals. And we show here the changes in inpatient days, average number of outpatient services provided, and surgical services provided. Next. Here we show the average efficiency score, or the output of the DEA model. We find that average efficiency pool across all hospitals in the sample increased in both inpatient and outpatient departments between 2013 and 2016. But trends were different for the contract status groups. Among non-contracted hospitals, average inpatient department efficiency decreased 4.7%, and outpatient department efficiency increased 14%. While among contracted hospitals, average efficiency increased in both inpatient and outpatient departments, which may be explained by the slight increases in installed capacity and human resources relative to large increases in inpatient and outpatient outputs, as shown in the previous 2 slides. Next. This table shows results from the 2 regression models. Our analysis suggests that contracting with BPJSK is significantly associated with increased efficiency in inpatient departments. Holding all other factors constant, there's a statistically positive effect of contracting with BPJSK on efficiency, or a mean change in efficiency of 3.46%. However, contracting status did not significantly affect changes in outpatient departments. Results also indicate that increased efficiency was associated with increased hospital specialization. That is, private hospitals with greater specialization, type B, had a higher efficiency than general hospitals, type D. We also see an association between increased efficiency and not-for-profit hospital ownership, suggesting that hospitals not operating for profit were functioning more efficiently relative to for-profit hospitals. Next. So our analysis uses this two-stage approach to understand whether efficiency changes are associated with JKN. Again, we found that contracting with BPJSK was associated with improved efficiency in inpatient departments of private hospitals, but no clear evidence that changes in outpatient department efficiency are related to JKN. There were several limitations to this study. First, it's noted we had a limited sample size with only 5% of private sectors included, and only 12 non-contracting hospitals and no Class A type hospitals. So results are not generalizable to the entire private sector. Second, we have not studied causal inference, so we cannot directly attribute changes in efficiency to JKN or contracting with BPJSK. And we can't control for measures that may have influenced inputs and outputs or the efficiency in the DEA estimation. And finally, data availability limited what inputs and outputs we could consider. So we cannot assess changes in quality, allocated or total efficiency of private hospitals in response to JKN, which could help to better understand the hospital landscape in the JKN era, posed in the introduction. And with that, I'll pass over to Kathy now.
Great, thank you, Rebecca. So my name is Kathy Cantelmo, and I'm a technical advisor on the health financing and economics team at Palladium. And as Arin mentioned earlier, I am now going to present a new approach and a tool for measuring technical efficiency within family planning programs, which we developed under the USAID-funded Health Policy Plus project. So the need for a new approach came about due to the current family planning financing landscape. Many low and middle income countries rely on external financing support for their family planning programs, but they're experiencing plateauing or even declining donor support as they achieve certain levels of contraceptive prevalence and as they transition to a higher country income status. And these countries not only face potential declines in funding for family planning, but also for other health areas like immunization, HIV, TB, malaria, which means health areas are competing for increased government spending. And macroeconomic pressures, particularly now during the current pandemic, may also threaten countries' ability to increase domestic funding for health, including family planning. And given these challenges in raising sufficient funds to meet countries' family planning needs, many countries now are turning to generate evidence to improve allocative and technical efficiency of family planning programs. And there are several allocative efficiency models available for policymakers in developing countries to apply to inform resource allocation decisions. And these mainly include spectrum and optima models, which have been developed and routinely updated to reflect the latest evidence on intervention costs and effectiveness. And two models, Optima Nutrition and the LiveSave tool, consider family planning interventions. But there are virtually no policy models available for assessing technical efficiency of health programs, let alone family planning. And existing traditional approaches for assessing technical efficiency in healthcare settings are not really sufficient for evaluating the technical efficiency of a comprehensive family planning program. So DEA is typically conducted at the health facility level, as we just saw an example of private hospitals in Indonesia. And this is not appropriate when we're trying to analyze inefficiencies at all levels of the family planning program. So not only service delivery, but also demand creation activities and central program management. And standalone studies for family planning technical efficiency are also quite narrow. So they look at how changes to some specific service delivery aspects, like task shifting or integration with other services, can result in efficiency gains. And since there was no existing tool for a comprehensive technical efficiency assessment of a specific health area, we developed one for family planning. We created a tool that could be applied in any country and customized for that country. The application process involves 3 steps. First, diagnosing inefficiencies within the program by developing deconstructed efficiency scores using input-output ratios for up to 26 specific components of a family planning program. So this takes a different approach than coming up with a composite score. And then the second step is identifying the root causes of specific inefficiencies. And the third step is evaluating potential solutions to inefficiencies using some specific criteria that we've specified in the tool. And the entire process involves significant engagement with and validation from key family planning stakeholders in country, including the government, donors, service providers, and civil society. And after applying the tool, the family planning program develops an action plan for implementing feasible solutions for technical inefficiency. And HP Plus will provide further technical assistance to monitor implementation of this plan. And we will pilot this new tool in 2 countries this year and make adjustments to the tool based on the pilots and then publish it for anyone to use going forward. So now I want to dive a bit deeper into the tool and application process. So we divided the family planning program into 3 areas: service delivery, demand creation, and program management. And based on expert consultation and literature review, we identified 26 family planning program components that are key elements to achieving service delivery, demand creation, and program management goals and require human and financial resources to implement. We spent a great deal of time deliberating on how to assess the technical efficiency of each component. We wanted something simple so that policymakers could use the tool without any advanced skills or the need to conduct a lot of primary data collection. And the most straightforward approach would be to compare unit expenditure across program components. The problem with that, though, is that relatively low unit expenditure could be a function of poor quality rather than efficiency, and some program components just require more resources than others, meaning it isn't really possible to lower costs any further, but we don't know that for sure without any other family planning programs to compare it to in our analysis. And most importantly, a lot of developing countries lack the detailed family planning expenditure data we would need to conduct such an analysis. So we decided to identify several input-output ratios for each family planning component that users could select based on their country context and data availability. And the tool automatically calculates the ratio based on data provided and uses criteria to determine if the ratio indicates potential inefficiency. And we benchmark efficiency using comparisons to other countries if data are available across countries or across components if such a comparison is appropriate. And most of the input-output ratios require standalone interpretations that are then validated by stakeholders familiar with the country's family planning program. And I'll show some examples of this. This slide just shows the 26 different family planning program components grouped by the 3 categories. So now I'm going to go through a specific example. So for adolescent-friendly services, that's one of the 26 components that make up the family planning program. We have 2 choices for inputs and outputs depending on the data available in a country. For inputs, we are measuring to what extent health providers are trained in or facilities are providing adolescent-friendly services. And this is based on best practice or country guidelines for what constitutes adolescent-friendly services. And this may include separate clinic hours and spaces for adolescents or specific educational materials and reproductive health for adolescents. And in terms of output, we would ideally look at the percentage of family planning users ages 15 to 24 who access family planning from a facility providing adolescent or youth-friendly services. We would want the ratio to be at least 1 in this case. If these data are not available, we can also use unmet need as an output. This ratio is a bit more difficult to interpret, but basically the higher the ratio, the better in most instances, because we want adolescent-friendly services to be implemented at scale and for unmet need to be very low. A key limitation is we cannot account for other factors that may influence these outputs. And there are many that could influence unmet need among adolescents and still keep the tool manageable or simple enough to use. And this is where stakeholder validation of our interpretation of the ratios comes into play to ensure that we have actually accurately assessed the level of inefficiency of a program component and the need to do a root cause analysis to better understand these issues. So once we identify the program components that may drive inefficiency within the program, we convene stakeholders to identify root causes of the inefficiency. The tool provides several root causes as a starting point for focus group discussions, but these are supposed to be further customized for the specific country. So using adolescent-friendly services again as an example, legal barriers may be applicable as a key root cause of inefficiency. Countries can invest in infrastructure, staff, and other inputs for providing adolescent-friendly services, but if the laws of the country require parental consent for adolescents to access these specific services that the government has invested in, then the investments could be wasted and perpetuate high unmet need among this population. Once we understand the root causes of inefficiency, we then brainstorm possible solutions to the problems, and we collect these ideas from key stakeholders and then have the stakeholders evaluate solutions based on 4 criteria. So first, how much the family planning program has control over implementing the solution. So the more control the family planning program has, the better. Some of the solutions might require other stakeholders, broader health systems changes, which are harder to actually implement. Also, how long it takes to implement. So the shorter time frame, the better to reap those efficiency gains. The third is additional costs to implement. So relatively lower costs of all the solutions proposed, the better. And perceived effectiveness of the solution. So we do not have actual data on how effective many of these solutions to address root causes are. Of course, we would use studies if they are available, but we will have to rely mostly on stakeholder opinion of the perceived effectiveness, and the higher effectiveness, the better. So the stakeholders determine at the beginning how to weight this criteria based on what is most important to them. And as I said before, after this step, the country develops an action plan for implementing the solutions that are scored as the most effective and feasible to implement. So as you can see, this tool takes a different and more policymaker-centered approach to understanding family planning technical inefficiencies. And it aims to establish a logical, evidence-based process to addressing inefficiencies in the family planning program. It's very oriented to action by policymakers to make changes for efficiency. Some strengths of the approach are that we're able to assess efficiency of specific family planning program components across multiple levels, not just service delivery. The tool is customizable, available for any country to apply, and it's also, there's multiple options depending on data availability. It uses specific inputs and outputs, and key policymakers and program managers are engaged throughout the entire process. Some limitations are that the ratio scores do not account for any covariates. By understanding root causes of inefficiency and validating things with stakeholders, we hope to mitigate this pretty significant limitation. Also, some ratios are more difficult to interpret than others, given the complexity. Some of the input and output indicators are actually composite indicators in themselves, so it's a little bit more difficult to interpret. And it does not assign overall technical efficiency scores for the entire family planning program. It also requires some pretty detailed data inputs, although most of the options include some data that we know are available from routine data sources and pretty regularly conducted surveys. And we hope that that helps to make the tool easier to use. And with that, I'm now going to pass along the floor to my colleague, David, to discuss another real-world example of assessing technical efficiency issues in health.
Okay, thank you very much. My name is David Haoya. I'm a Senior Health Finance Advisor at Health Policy Plus project in Kenya. I am an economist. Now I present to you what HP Plus is doing in 7 counties in Kenya in support of technical efficiency using process measures, as was said by my colleague Ari. Now, just as a quick background, there are 47 counties in Kenya, and they form subnational level of government. Ideally, they receive a share of the national revenue, which they appropriate to departments according to their priorities. So before I go deeper, I want to answer this question, why we care about technical efficiency in Kenyan counties. So next slide, please. So it's a legal requirement for counties in Kenya to spend public resources efficiently and transparently, and this is provided for in an act of parliament where there's an article that actually stipulates who should monitor this. Another thing which we have observed is that there is plateauing in budget allocation to health in the counties, and now it's approximating about 27% of the budget. Hence, the need to prudently manage those allocated resources to achieve the same level of output or even better outcomes. Now, improvements in technical efficiency, therefore, is an avenue of application for the public finance management principles, which can increase resources to health, because now the fiscal space is limited. Next, please. Now, our approach in Kenya, in the counties, is two-pronged. We use capacity building, where we build capacity of county teams to be able to prepare their budgets in program-based budget format. And you will see shortly how this actually thinks about technical efficiency in advance by linking inputs to outputs. The other approach we use is to support counties to generate evidence which informs technical efficiency. And I will be taking you through some ratios which we have used to be able to identify areas of improvement. Next, please. Next. So, in quantifying inefficiency in Kenya, in spending in Kenyan counties, we note that existing approaches like my colleagues have just mentioned, like the DEA, are not readily available because of the issues of capacity, but also even when the coefficients from such sophisticated approaches are computed, they are not easily interpreted and applied to the real situation, because when you get a coefficient and you don't know where you fix before you improve efficiency or how you compare between two counties, it becomes challenging. So our approach is to use simple and descriptive techniques to obtain a level of performance of a given health providing unit, and in this case, we are talking about counties. And then we interrogate those ratios to be able to see where we can improve in terms of technical efficiency. Some of these ratios we are talking about are basically expenditure ratios, and they are easy to compute, and they can actually be computed at the level of the counties with the county staff themselves without much assistance. So we will be looking at some of these ratios. We also have workload ratios and bed ratios, which we have used to be able to pinpoint areas of improvement. Next, please. Next slide, yes. So next slide, in terms of capacity building, like I've said, HP Plus in Kenya has developed program-based budget curriculum and the manual, which are then used to assist or to build capacity, or used in the training of county staff to build their capacity to prepare budgets or their budgets in program-based format. And like I've said, this is in line with the financial reforms that are sweeping in low and middle income countries to be able to prepare their budgets in program-based format or results-based format. And one attribute of such budgets is that you are able to link inputs to outputs. And by so doing, you are basically thinking about technical efficiency even before execution of the budget. Next, please. The next approach is where we support counties to generate evidence. And next, please. And in doing this, what we have done is to come up with simple descriptive ratios, like I've said. And in this case, what you can see, these are the counties that what we call our focus counties, the counties we support. And the first three, for example, three rows are giving us ratios that we've just generated by dividing very simply, the county government health expenditure and the service output. And in this case, we are talking about, for example, outpatient visits. And one can quickly see a lot of variation across the counties. And there are quite a number of reasons that we can give to explain these variations. And one of it is basically the fact that these are counties of different sizes. And we also have some counties here who are previous regional facilities which had a lot of infrastructure. So in terms of maintaining this infrastructure and even the staff, the budgets are definitely much higher than if you were to compare with other smaller counties. However, even when we net out all these variations or sources of variation, we still are able to see certain variations still there. And so what we normally do is to bring together technical staff from these counties to be able to discuss and come up with actionable activities that are actually aimed at improving some of these ratios. Of course, we are not saying that the smaller the ratio, the more the technically efficient the county is, because as you were told earlier, the smaller ratio could be actually a sign of poor quality as opposed to efficiency. But what we say is that sometimes we even look at the trends, and my next slides are actually looking at the trends in some of these ratios to try and see whether there is any improvement or not. So next slide. So for example, what we observe here is a general decrease in health expenditure per service output in a few of the counties. Of course, I need to mention here that our focus on technical efficiency has been in the last 2 to 3 years. And therefore, what we observe here are results that are starting to sort of mature in terms of counties trying to implement some of the actions they have come up with. So you will see a lot of mixed results, but there is a general decrease in the health expenditure per service output, which you can observe across the majority of the counties. Next, please. Here we have done the similar analysis, but using only personnel emolument or personnel expenditure. And you can also see that just like the previous slide, there's some improvement across some counties, but the other counties where we have not spent so much time on technical efficiency, we still have to do much more. But having said that, next slide. Yeah, having said that, these results, despite the fact that they look very simplistic, they have actually led to a shift in the way counties are allocating their resources. And this has come as a result of counties or county teams appreciating the need for accurate data, because part of the reasons that counties were giving when we were showing or discussing these ratios were that some of the numbers are appearing that way because certain expenses maybe were not debited correctly in the right place and so on. And in some cases, like in Mombasa, they actually using the evidence they saw out of this discussion, they decided to undertake a human resource audit and identify that some of the bills that were debited to their department were actually for other departments or for staff who were not actually able to be traced. And through such corrections, you can now see that the allocations are now able to stabilize, where the county is able to reduce the expenditure per, especially on recurrent expenditure for PE. And more importantly is that we've had counties, after realizing what is happening in their trend, they have replaced, for example, retiring specialized doctors with contract doctors, like in the case of Mombasa, where because contract doctors, like we say, they are more, cheaper compared to specialized doctors who are employed on permanent and pensionable basis. So we see most counties, if we were to show the results for the counties, we see most counties reducing their proportion of recurrent expenditure allocated to PE. And this is coming because of the discussions we've had by just analyzing these simple ratios. So we hope that going forward, as we get more data, we should be able now to apply slightly more sophisticated approaches so that we can now confirm some of the numbers that we have seen through this simple analysis. Thank you very much. Over to you, Mr. Marine.
Thank you, David. So I think we can take some of those questions that have come in through the chat, and please do type in a few more. So I think the first question was from Bruce Hollingsworth on the choices that we made in the DEA analysis for Indonesia. So I'm going to let my colleague Rebecca talk a little bit about that. And then also the question from KK Lim on the selection of the types of variables that could be used for such healthcare analyses. So Rebecca, if you could try and answer those, thanks.
Yeah, thanks for these questions. For the output orientation, we were assuming that hospitals plan budgets in advance and don't have ability to quickly adjust investment in infrastructure, equipment, labor. So we were orienting the DEA models to maximize hospital output. And for the other question, thank you. I agree that choice of inputs and outputs is really important, and if depending on the mix, your score for each DMU would change. I would say the selection needs to be grounded in some evidence of relationship between inputs and outputs. For our analysis, we were using what data we had available.
Yeah, thank you, Rebecca. And I think just quickly to add to the question from KK, I think the selection of output measures could possibly include a quality measure, and certainly hospitals do collect quality data, especially in the developed country setting. But I would caution, I guess, and it'd be great to get some perspective on this in the chat, that any quality measure used must have some governing principle or theory that comes from the literature or from experience that associates it with the input measures used. So for example, what theory or principle do we have for connecting a quality measure, reported quality measure like patient satisfaction, with an input like number of beds? Perhaps there is one, but I think this is a choice that has to be governed with a mix of art and science. Thank you for those questions. I'm going to take some other questions. There's a question from Piyush on students learning DEA. What are some of the data sources? In fact, in the chat, one of the colleagues has mentioned a large book that is available for practitioners. This is being generated by the WHO's European Observatory. It's also cited as a shorter form paper in the presentation here. So if you could actually click to the references, please, the next slide, and we can have that on the viewer. Thank you. So I think Piyush, you may be able to open that report and as well as the book, because both are free resources available online. And then we also recommend perhaps reading the Stata Journal, which is available for free, as it has a very nice visual working of the simple concepts behind DEA, whether you're using input minimization or output maximization. Thank you. There is a question again on Indonesia. I think this is something that's developing right now on how the Indonesian health system is responding to COVID-19 and health system efficiency. We don't have any information on this. Of course, it'd be fascinating to use COVID-19 as a natural experiment and to compare what happens to health system resource use in situations like this, which give you an unprecedented sector-wide experiment in reduced utilization, but consistent use of hospitals that still remain open, and I think comparability of different situations and cases depending on the epidemic in the local context would perhaps yield some interesting experience. So I think we can stay tuned. I think there will be a deluge of papers coming soon on efficiency and health system use during COVID-19. There's a question on, could stochastic frontier analysis methods be applied instead of DEA? If not, why? And if yes, why wasn't it used? So I think by no means did we do an exhaustive survey of the differences and the applicability of stochastic methods, which of course, since they are rooted in econometric methods, require a specification of the production process so that coefficients can be generated. So we would need to have some kind of a methodology linking the outputs, the output and the inputs. And I think that is of course something that is a little bit restrictive, but then it pays off in terms of better defined error terms and hence a better understanding of a function, production function that could be then parameterized using regression analysis. So I think there's places where that approach works and there is a literature out there. I would say that the literature on stochastic frontier analysis application to health systems is very limited. Again, mostly due to the improved strengths of DEA as a way to look at the complex processes and possibly unknowable processes that are inherent to health systems decision-making and health systems production of outputs. There is a question to David. David, could you respond to the question on whether the program-based budgeting curriculum is available?
Yes, this curriculum plus the manual are available on our website, and in case anybody has challenge accessing them, please let us know, because we've used them for quite some time and they are now very familiar documents on the website.
Thank you. So just for everyone, our website is linked in the chat. Please do take a look. It was in response to a question, healthpolicyplus.com. Kathy, could you respond to the question on how can you present technical analysis to advocate for more funding, say, for example, for family planning or other types of programs?
Sure, this is kind of a complicated question and encompasses almost a whole portfolio of work that we do at Palladium in terms of translating technical analyses like a DEA or a model application to advocate for more funding. And basically, we distill the key messages down in into talking points where we present the information with graphs, lots of visuals, and briefs. We basically try to disseminate messages through media and other avenues too, so that it can reach the public and key decision makers. I don't know if I'm fully answering your question, but sometimes it's more important to focus on interpretation of the results rather than on the methodology itself when you're talking to key policymakers. Of course, some people, like health economists within the Ministry of Health, will want a solid explanation of the methodology and to work with us on the analysis. But a lot of times, some of the key decision makers, like parliament members or non-economists, would really appreciate kind of the stilled visual results.
Yeah, and I would just quickly add that one of the common critiques in terms of our work in developing countries is the health sector is not efficient in converting financial resources that are allocated to the health programs, health sector overall by, say, the Ministry of Finance or the Ministry of Planning, versus other sectors, say, for example, education, where the link between input and output can sometimes be easily observed or easily tracked. So I think efficiency analyses cross-sectorally are very difficult to perform, but inherently, if we can show at least that efficiency measured within the health sector and tracked over time say, for example, using the types of scores that both Kathy and David have presented today, are increasing, and that increase is robust across different decision-making units. That is very helpful to make the case to people who hold the budget, who hold the purse strings. And I think this is inherent to our work over on the health sector. So I'm going to thank our presenters, my colleagues today, and everyone for joining. Over to you, Pavitra.
Thank you very much, Arin, Kathy, David, and Rebecca. Thank you all the participants. From iHEA, we all welcome you to actively involve yourself in the activities of FSEG, Efficiency Group of Health Systems Examination. And you can check our activities in our webpage. You can align yourself, your aspirations with our objectives, and feel free to write to me. So hope to work together in coming days for these important global policy issues. Thank you very much. Hope you had enjoyed well, and see you soon again in the next program. Thank you, Nicole and Natalie, and all participants will be receiving the PowerPoint presentation slides as well as the recording from iHEA office. Thank you again. See you soon for the next program.
Thank you, Pavitra. Goodbye.
Bye-bye.